Good to see everyone. Good morning. My name is Yushen Qian. I am a clinical assistant professor of radiation oncology here at Stanford. I work in the Stanford South Bay facility, which is in San Jose. And it is a pleasure to be talking to you today about prostate cancer. I want to thank the organizers of this event for giving me this wonderful opportunity. So, what is radiation therapy anyway? Radiation is a curative intent treatment option for prostate cancer. There are primarily two ways to deliver radiation for prostate cancer, and we'll categorize these as external and internal radiation. External radiation can be delivered with photons, most commonly, or protons. And there are very various terms you might hear out there. And for simplicity, these are mostly technical terms that refer to the way external radiation is delivered. But you may come across them in your readings, such as IMRT, VMAT, SBRT, and SABR. Internal radiation, also known as brachytherapy, is delivered with a small radioactive source, which is, and depending on the type of radiation, that source may either be permanently placed or temporarily placed. And we'll get to talk about this later. So in terms of treatment options for prostate cancer, these are mostly determined by what are called a risk group. We primarily use the NCCN, or the National Comprehensive Cancer Care Network, risk groupings. And these are primarily determined based upon a couple of things. The tumor stage, which is determined from either a digital rectal exam or the MRI findings. The Gleason score, which is determined from a biopsy, as well as the PSA level, which is determined from a blood draw. On the right, you can see how we can clinically stage prostate cancer based upon a physical exam or an MRI. And the risk categories in general are broken down into three main risk groups: a low risk, a middle risk, and a high risk. So here I'm showing each risk group, the definition of what the risk groups are, and the available treatment options in terms of radiation. For simplicity's sake, because Dr. Sun has already talked to you about surgery, I'm not listing surgery here as a treatment option, but just know that there are various surgical options available. But the general trend you can see is that depending on your risk group, the treatment varies, with, in general, a trend for more intensified radiation, more intensification of treatment with the more advanced disease that we have. So for example, whereas a low-risk patient can potentially just get radiation treatment alone, a patient with a high-risk disease may be recommended to get a combination of external radiation, internal radiation, as well as hormone treatment. This is a slide showing the treatment schedule of various forms of radiation therapy that you may come across. And radiation treatment courses tend to be prolonged over many weeks. And the reason we do that is that by spreading the radiation treatment out over multiple treatments, and sometimes your doctor will call each treatment fractions, we're able to maximize tumor control or tumor killing while minimizing the side effects to normal adjacent tissues. In general, all of these different schedules have about the same, what's called biologically effective dose, or biologically effective effect with respect to radiation, the radiation dose, the tumor control, and the side effects. And depending on the technique that is utilized, the schedule can be different. For example, there are many ways to deliver radiation treatment shown. And in the first sort of line is a standard 40 fraction or 40 treatment regimen that lasts over 8 weeks. We rarely do this now. More commonly, radiation is delivered over a just over 5-week regimen. And again, this is 5 days a week, Monday through Friday, where and Saturday and Sundays you would have off. Brachytherapy, or internal radiation, is typically given over 2 sessions if it is just brachytherapy alone. And when given in combination with radiation, it is given with 1 session. Next slide. Okay. You may hear multiple different terms or names for the type of radiation machines that are used. And this is a slide showing essentially modern machines that we use for external radiation. The workhorse of the machines that we use here at Stanford are from Varian, and these are linear accelerators. And we use primarily the Varian TrueBeam. However, we also have other radiation machines available, such as a CyberKnife, which is able to deliver radiation, a different type of radiation called SBRT. Varian machines can also give that. And then there's also a ViewRay machine you may hear about as well, which uses a combination of MRI guidance in real time to adapt your radiation plan. And Stanford is one of the first places where we have what's called a reflection, biologically guided treatment machine. This is still in the investigational phase as we are working out the protocol to best find a way to utilize this machine for prostate cancer. So next slide, I thought it might be helpful to show sort of a video of linear accelerator in action. So let me see if I can play this. Great. So here's a video of our therapist setting up a patient for treatment. One of the things I want to note is, and patients often have these questions, is you can see that the machine is, here I'll play this again, the machine, the room is quite large, and the machine is moving around as it delivers treatment to the patient. And then here is another video showing the machine moving around in a 360-degree angle. And the way that the radiation is delivered is that as the machine moves around in a full arc, little beamlets of radiation are coming out at various angles, and all these beams of radiation converge at the center of the target, which is, in general, your prostate. Okay, next slide. Great. Okay, so what is the goal of radiation? The goal of radiation is to deliver the maximum tumor dose to the target, which shown here is your prostate, while minimizing the scatter dose to adjacent organs, such as your bladder and your rectum. And we're able to do this both by internal and external radiation, and I'm going to show you how. This is a slide showing various forms of external beam radiation therapy, whether with the most common form known as IMRT, intensely modulated radiation therapy, as well as proton therapy, as well as highly hypofractionated therapy called SBRT. And basically, in this slide, the red color shows essentially where the high dose is, and the blue color shows where the low dose is. And as you can see, ultimately, our goal of treatment is to get really the high dose into the target, which is the prostate. But in order to get there, there's going to be entry and exit levels of radiation showing in the blue in order for the radiation to get to the target. Brachytherapy let me see here. So brachytherapy is a form where the radiation is directly delivered directly into the prostate. And there's various forms of brachytherapy available for many different cancers: breast cancers, brain cancers, prostate cancers. But in prostate cancers specifically, there's low dose rate brachytherapy as well as high dose rate brachytherapy. And they differ based upon the type of radioactive source that is used. At Stanford, we use the more modern technology called high dose rate brachytherapy. So the advantages of brachytherapy are, because of the radiation is directly placed into the target, there's no entry or exit dose. So this is the ultimate form of trying to minimize side effects to your adjacent organs. And with low dose rate brachytherapy, which consists of implantation of permanent radioactive seeds, versus high dose rate brachytherapy, which is temporary placement of a radioactive source that sits there temporarily. So at Stanford, the procedure is essentially a 3-hour procedure delivered with general anesthesia. And our brachytherapy team will essentially insert temporary needle catheters through the perineum, which is the area between the scrotum and the rectum. And these catheters will essentially crisscross the prostate. And a radioactive iridium seed will sit and dwell for a couple minutes at a time in certain positions and deliver the high dose rate radiation there. Once the procedure is complete, everything is removed. You're able to go home the same day. You're not radioactive. You can be around kids. And then here's the machine that controls the radiation source, otherwise called an afterloader. And what is going on is that you can see in the top, the first picture, that there's a radioactive iridium-192 source. And after your brachytherapist connects each of these catheters to the machine, the machine will unload that source, and the seed will travel out from the machine to the catheter, deliver radiation for a period of time, come back, go to the next position, and it will keep doing that until the procedure is complete. And again, once completed, you're able to go home the same day, and in general, there are no restrictions. Okay, so let's talk about some of the side effects from radiation. So in general, I think of side effects in terms of short-term side effects that are temporary and will eventually go away in about 2 to 3 weeks after treatment. And these side effects can include a variety of things. General side effects such as fatigue, and in general, feeling like you may need to take a nap in the afternoon. And other side effects related to local irritation of, for example, the bladder, which may lead to urinary frequency, getting up at night, as well as irritation of the bowels, which may include loose stools or diarrhea. Long-term side effects are ones that come up much later on after you're done with treatment, and these are the ones that stick with you forever. And ultimately, it's important to note that severe long-term side effects are rare, and only really a minority of patients experience them. The potential side effects, again, are related to inflammation of the surrounding organs, the bladder and the rectum. So urinary bother, such as permanent frequency that may require the use of a medication to help optimize urination. Less commonly, chronic irritation of the bladder that may result in blood in the urine or spasms or pain. Irritation of the rectal wall or the lining of the rectum that may cause mucus or blood in the stool, as well as rectal urgency. But as Dr. Chen alluded, more commonly over time at 5 years, there's a pretty significant chance of erectile dysfunction requiring the use of a Cialis or a Viagra or other non-pharmacologic measures as well. I should also note that it is very rare, but radiation does have a non-zero risk of causing a second cancer. We think that the risks are somewhere about 0.3% per year. And in general, if they occur, they're related to the organs, the bowel, the bladder, that the radiation is nearby. So just a quick note about postoperative radiation. So occasionally after surgery, depending upon what the pathologists find from the surgical pathology, there may be a need for use of radiation after surgery. And this is a case-by-case basis. Sometimes you can hear about it as either adjuvant or salvage, depending upon the exact situation, specifically what the PSA is looking like after the surgery. But this is only delivered using external beam radiation treatments. It's about 35 treatments for 7 weeks of treatment. And hormone therapies typically involved, and again, decided on a case-by-case basis. So I want to talk a little bit about sort of what we at Stanford, sorry about that. We're having a little bit of technical difficulty where the screen went off. But somebody's helping fix it. But let me talk to you a little bit about one of my interests too. And I think one of the really big advantages of having treatment at Stanford is that Stanford is an academic institution where we're always looking to find the next best treatment for the next generation. And in doing that, we do that by offering clinical trials to patients. And one of our most recently open clinical trial available for high-risk prostate cancer patients is called NRG-GU009. And what that is that's a national group, so many academic institutions across the nation are participating, phase 3 randomized controlled trial for high-risk prostate cancer patients, where we are trying to tailor your treatment based upon the results of a genomic test called a Decipher test that is trying to, that is trying to look at how aggressive the cancer is genomically beyond just the traditional NCCN risk groups that we talked about before, PSA, MRI findings, Gleason score. So that's a trial I'm very excited about. Furthermore, at Palo Alto, we have several trials available looking at potentially using urine or blood tests other than PSA to measure the response of prostate cancer before and after treatment. And then there's also, furthermore, if you're eligible for brachytherapy, an imaging clinical trial where we are trying to utilize MRIs and PSMA PETs prior to and after brachytherapy to assess response to treatment. One of the things I would like to suggest is, if you're interested about this, ask your doctor what clinical trials are available to you. And then that's it. So I wanted to, again, say thank you so much for your attention. Wanted to give, again, say thank you to the organizers for letting me speak, as well as my predecessor at this event, Dr. Bagshaw, for helping me with this talk. Yeah. Go ahead. Yeah. And then another thing I would like to just sort of make a note is that you're here at Stanford and Palo Alto, but Stanford is really more than just a location. It's a brand. We are a brand of medicine with various team members of our medical team all throughout the Bay Area. We have specialists obviously here. I practice myself in the South Bay in San Jose, Los Gatos. We have experts in the East Bay as well as the Central Valley. And are one of the things that I am most proud of is that we practice Stanford brand medicine. And so you don't have to come all the way over here to Palo Alto. If you would like to get treatment closer to home, I'm willing to bet that there are Stanford facilities close to where you are, and the practice patterns that we all practice with are homogeneous and standardized. So hopefully that makes it easier for you.
Thank you so much, Dr. Qian. We have some questions.
Happy to take questions.
Okay. Starting with the live chat questions, are there synergistic effects of radiation and hormone therapy?
Yes, there are absolutely synergistic effects of radiation and hormone therapy. Multiple clinical trials have demonstrated that there is a benefit when we add hormone therapy in certain cases of prostate cancer. Specifically, let's take an example. In high-risk prostate cancer, we typically recommend between 18 to 24 months of hormone therapy. That might change 5 years in the future because we're currently doing the clinical trial, that GU009 trial, that is asking the question of, well, for patients who have a low genomic risk, is giving you 2 years of hormones too much because side effects, erectile dysfunction? Can you get away with 1 year? And for patients with high risk, with a genomic test that shows that the cancer is aggressive genomically, we're asking the question of, do you need something else in addition to the 2 years of hormone therapy? Can we keep improving on outcomes?
Okay, thank you. And can you discuss about how to make a decision between external radiation and brachytherapy? And as a follow-up, is there anyone who is a bad candidate for brachytherapy?
Yeah, that decision making, I would say, is best made in combination with in a shared decision making process with your physician. But in general, if you're eligible for both, some patients want this taken care of very quickly instead of in 2 weeks of treatment, 2 sessions, 2 weeks of treatment, versus coming in every day for 5 weeks. And then clinically, there's some other factors that, to give you a peek, we think about is patients who may not be the best to just have brachytherapy itself are if you're already coming in with a very large prostate and you already have a lot of urinary side effects. There's data showing that your urinary toxicities can be worse with if you have high baseline urinary scores or symptoms to begin with. So big prostates, sort of high urinary symptoms, extension of disease elsewhere in a place where the brachytherapy needles may not be able to access. Again, it's a complicated case-by-case process.
For those men who do have the large prostates, they get a TURP or a procedure and then have radiation?
They can. So the TURP before brachytherapy is harder after a TURP. I would encourage you to encourage you to talk about the procedure before you undergo it in conjunction with both your urologist as well as your radiation oncology doctor. But obviously, if you're considering external beam and you have a lot of urinary symptoms to begin with, having a TURP either before or after the treatment may be necessary.
Great, thank you. Another question. Can you have surgery after radiation?
Yes,
and vice versa?
That is a great question. That is a question as old as time, in that it depends on where you ask. It is common for patients to have surgery first, and then what can happen is either the PSA either remains undetectable, but then there are several high risk factors that make you worried about recurrence, for which case your radiation oncologist may think about adjuvant or post-operative radiation. This is less common now than it was a decade ago. Our practice has kind of shifted towards what's called early salvage, which is looking at the PSA and waiting to salvage a PSA when it starts coming up. We want to act quickly so that, because outcomes show that giving you radiation when a PSA starts recurring after surgery, when the PSA is low, is better than waiting for the PSA to get really high. But we also want to give you as much time to maximize your quality of life before we act. So that's one situation. Oftentimes, patients will come in and talk to me, and they'll say, I've talked to my urologist, and they'll say, and I don't want to sort of step on the urologist's toes, and they'll say, I've heard from my urologist that I can never have surgery after radiation. At the risk of and just speaking, I would say never, but we have some of the best urologists here at Stanford, and if it's really the right thing to do, it's worth a consultation, and it does get done. It does get done, but you want it that in that situation, you want the surgery to be done at a high volume academic center with an academic surgeon.
What are the concerns with doing surgery after radiation?
Okay, so I'm going to put my pretend surgeon hat on. But after radiation, there can be some scar tissue in the area that potentially muddle the interfaces, for example, between the prostate and the rectum, so that when you, correct me if I'm wrong, take off the prostate, there may be a little bit more increased risk of, for example, damaging the rectum, damaging the adjacent soft tissues around. Hi, Sharon.
Wait, microphone.
Oh, it's fine. I have a very loud.
It's for live stream.
Hi, Yushen. So my question for you is, when you are doing a combination radiation therapy with external beam and brachy, how often does prostate cancer actually recur within the prostate gland?
So it depends upon the state. It depends upon the stage it depends on the risk group of the prostate cancer. But in general, I would say that a combination approach, which is our most aggressive approach, so combination external radiation and internal radiation together, we think of as a little, just giving you a little bit more in terms of local control. It's treating the prostate a little bit stronger than just with the external alone. It's giving it a little bit more. That in combination with hormone therapy for high-risk prostate cancers, we're still hoping to give you cure rates of 80% or above, depending on the situation. And we sometimes do this regimen of the combination approach for variants of middle risk prostate cancer, ones that start to look a little bit more high risk, but less, but not really high risk there as well. And we're hoping, cure rates there are still 85, 90% or above.
Thank you. 2 more questions, and then if you can provide your contact information.
Oh, sure.
And this should be a quick question. When you say large prostate, what are we talking about here?
Yeah, in general, when you get a prostate, when your urologist does a digital rectal exam, or when you get an MRI of the prostate, there'll be an estimation of the volume of your prostate gland. And in general, prostates above 60 cc start getting into the large prostate range.
Thank you for clarifying. Last question. What are trade-offs between the 5 weekly treatments and the 5-week treatments once each day?
5 weekly treatment. Let me try to understand that question. 5 weekly treatments. So once per day.
Once a week for 5 weeks? versus daily for 5 weeks. I don't know if that was misunderstanding, but I maybe thought I missed it.
We do not have a once a week for 5 weeks. So, oh yeah. So SBRT is 5 treatments that are given essentially once every 2 days or every other day, versus sort of our most common regimen, the 26 treatments, which is Monday through Friday, 5 days a week, for 5 weeks, plus a day to be exact. So SBRT is a good treatment option for predominantly lower risk disease, specifically low risk and lower middle risk disease. It's also a good treatment option for patients who really have potentially like a resource or a time limitation, where they really want to sort of get done quickly, but somehow there's the internal radiation itself isn't optimal, maybe unable to get anesthesia, or still want it to be a minimally invasive technique, but want to get it done quicker. So there's various sort of little nuances, but in general, the biologically effective dose, the cure rates, and the side effects in general are about the same.
Great. Thank you so much, Dr. Qian. That was an amazing presentation. We appreciate your time today.